Last time, I introduced the steps I use to start a new tube feed, complete a nutrition assessment, consider refeeding risk, and calculate and write orders. The previous video focused on nutrition assessment. Today we are going to talk about how parts of your assessment help you to consider a patient's refeeding risk and how that risk informs your plan. A BMI lower than 18 and recent weight loss of more than 5% of body weight are anthropometric risk factors. The lower the BMI and the greater amount of weight loss, the greater the risk. The amount of fat and muscle loss determined from the physical assessment also predicts risk. The greater the amount of wasting, the higher the risk. Low serum levels of potassium, phosphate, or magnesium are lab markers you will be looking for to determine risk. The lower these are, or if they have recently been low and needed repletion, the greater the risk for refeeding syndrome. Recent caloric intake is very important to consider. ASPEN defines moderate risk at minimal to no intake for 5 to 7 days, or less than 75% of estimated needs for more than 7 days during an acute illness, or less than 75% of estimated needs for more than 1 month in the absence of acute illness. This is really not very long. Many hospitalized patients have minimal intake for 5 or more days during their hospital stays. Patients who have certain diseases or conditions may also be at an increased risk. This may include cancer, eating disorders, alcohol or drug use disorder, GI conditions such as short gut syndrome or Crohn's disease, recent surgery, dysphagia, AIDS, hyperemesis, and more. All of this said, this means that the patient's weight changes, lab values of potassium, phosphate, and magnesium, recent intake, and medical conditions are going to be the primary components of your assessment that indicate the risk of refeeding syndrome. That's great that you can identify a patient's risk, but what do you need to do about it? Your role as a dietitian is to feed the patient as safely as possible and to collaborate with the physician, as they will be responsible for medical management of refeeding syndrome. ASPEN recommends feeding 10 to 20 calories per kilo for the first 24 hours and advancing by 33% of goal every 1 to 2 days. Remember that this includes calories from all sources, tube feeds, IV dextrose, and oral intake. ASPEN also recommends repletion of electrolytes prior to initiating feeds. Increasing calories should be delayed when levels are severely low. It is also recommended to supplement with thiamine and to continue to monitor electrolyte levels. In cases of severe risk or severely abnormal electrolytes, patients may need continuous cardiac monitoring. Remember to talk to the doctor about your assessment of refeeding syndrome risk and discuss the recommendations that may not be within your scope of practice to order. What do I do now that I've got a feeding plan? How will I know if my patient is refeeding? ASPEN defines refeeding syndrome as a decrease in potassium, phosphate, or magnesium in the first 5 days after increasing energy provision. This could be a decrease in 1, 2, or all 3 of these electrolytes. Mild refeeding syndrome is a decrease by 10 to 20%, moderate refeeding syndrome is a decrease by 20 to 30%, and severe refeeding syndrome is a decrease of more than 30% and/or organ dysfunction resulting from abnormal electrolytes or severe thiamine deficiency. Electrolyte repletion is the #1 treatment for refeeding syndrome, but other interventions may include thiamine supplementation or multivitamin supplementation. You may choose to slow the rate of advancement of calories, particularly if electrolyte levels are difficult to correct. I hope this video gives you more of an understanding of what to look for when assessing a patient's risk for refeeding syndrome. This is an essential part of a dietitian assessment, especially when initiating nutrition support. We will see you next time for the tutorial on how to calculate and write orders.